Hello everyone and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams and today we have invited Matt Ignacio to speak on professional readiness, attitudes, and values. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We are always welcoming suggestions of topics or speakers, so please feel free to make suggestions in either the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available upon request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction of the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. And Mr. Ignacio has expressed that he will be taking questions throughout, and he'll be watching for those. So please submit your questions as they come to you, and he will try to address them right away. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's presenter is Matt Ignacio. Mr. Ignacio has been working with us at the National American Indian and Alaska Native ATTC for a few years now. He has taken the lead on helping to develop our Native LGBT and Two-Spirit curriculum, and has been a huge part of putting that together and putting together a team of people to create that curriculum. And he also has worked for the National Native American AIDS Prevention Center as a project manager, overseeing 4 federally funded training, education, and capacity building assistance programs. Matt, I don't think I updated this before I went on my leave, so I apologize. I don't have information on your bio here about your current project and what you're studying right now in your PhD program. So I apologize. Would you mind telling us what you're doing now?
Sure. Good morning. Well, I'll wait till you're done. How's that?
Yes. Let's see. Sorry about that. I'll pull up your slides for you, and yeah, thanks so much, Matt, and I'll hand things over to you now.
Great. Thank you so much. Good morning, everybody. Thanks for taking time out to join us this morning. Well, right out the gate, if the volume on my speaker is too quiet and you can't hear me, just type a little message in the window, and I will be sure to adjust accordingly. So my name is Matt Ignacio. I am a member of the Tahna Atham Nation, and yes, I did work for the National Native American AIDS Prevention Center, and yes, I did help out on developing a curriculum addressing the needs of Native LGBTQ and Two-Spirit individuals. Currently, I am a first year, well, actually, yeah, I guess I technically am still a first year doctoral student at the University of Washington in Seattle. We just finished up our first year, and there's some exams over the summer that we were required to take, and so starting in the fall, I will be officially a second year doctoral student at the School of Social Work here at UW in Seattle. So, with that, I'm here to talk about professional readiness and some of the values and attitudes that go along with that. I do not consider myself an expert at all by any means, but what I do know is that in the journey that I've been on, roughly 15 years working in HIV, working in the HIV/AIDS field as it relates to Native communities, there were just some things along the way that I've learned, that have been taught to me, that I've seen in various settings with regard to how people interact with each other, and all it basically really comes down to is a level of respect, and that comes from a personal perspective, being Native and having a lived experience, and then also having a professional experience working with Native communities, and certainly reflecting on issues with regard to privilege, with class and with race and identity, et cetera, et cetera, et cetera. So that was a very long intro to very important information, and like I said, you all, I don't consider myself the expert in this dialogue. You all are the experts in this conversation because you are frontline. You have that expertise of the needs of your community, and I'm merely just offering my framework or what I work off of, and hopefully that will inspire you and help you in the work that you all are doing. Because at the end of the day, what matters most is how well and how healthy our communities are, no matter where we come from. We want to have strong families and strong friendships, and when those who are sick, we want to see that they get the treatment and the help they need, and those that are feeling down and sad, we want to make sure that they have the supports they need. So that brings us to today. Again, that was a very long intro. You'll have to bear with me. As you can see on your slides, these are some of the topics that we'll talk about. Please feel free to jump in with questions, and let's take it from there. Okay, so let's clarify some values that we embrace working in the helping professions. So just in general, think about the standards of care that guide your very own work. Certainly in this process, we may ask ourselves, where is my knowledge and skills best used? Am I getting the support I need to help the people we serve? Do my individual practice standards and or values conflict with the organization's expectations? An example of that really is around, just that I've experienced on this journey, is really around drug user health. I'm a product of DARE, the DARE program in the 80s, where it's sort of a Just Say No campaign, abstinence-only education. And when I went to work for the Harm Reduction Coalition in New York City, very polar opposite perspective. We embrace drug users' health. We fight and advocate for drug users' health and justice. Just because you use drugs doesn't mean you're a bad person. And so, looking at my own value system that I was raised within, and then looking at the organizational value structure and trying to find a middle ground where I'm getting some clarification and clarity around where my values sit, is kind of ground zero. That's where we all begin. As we know, standards may be set within the organizations we work in, certainly looking at our overall agency missions and goals, really taking a critical look at those mission value statements and aligning our values with that. And if we don't align, then we might take an opportunity to consider other employment opportunities, right? We ask ourselves, whose needs are being met, ours or the client's? When I've worked at organizations that wanted to be housed in a big, fancy, shiny building, miles and miles and miles away from the local Native community, and our building had parking and was accessible to freeways, the question then is, whose needs are being met? Are we self-serving and meeting our own staff needs by living in a luxurious building, or do we need to situate ourselves closer to the local community? Those are ongoing questions that we ask, and certainly I don't know if there's a right or wrong answer, but those are just dilemmas that we have to get clarity on. Standards can also be set forth by our own profession. By training and by, I guess, degree, I am technically a social worker. I don't necessarily identify as a social worker, but I did, upon completion of my degree, agree to the following examples of codes of ethics. And codes of ethics set forth by the National Association of Social Workers articulate the basic values, ethical principles, and ethical standards that guide my work as a social worker. Here are some examples. So, commitment to clients. That is, that I am agreeing to promote the well-being of clients and that the client's interests are primary. So, given that, the example I used about the big shiny building located miles and miles away from clients, right at the gate, there's a conflict, right? You can see that maybe wouldn't be the best location if, in fact, I have a commitment to the clients that I serve. Another example of a value is self-determination. I aim to respect and promote the rights of clients to make their own decisions for their own lives. And another example is cultural competency and social diversity. And this is really with the goal to seek and understand the nature of social diversity and oppression with respect to race, ethnicity, national origin, color, sex, sexual orientation, etc. So those are some examples of values that guide the work that are independent of who I am, where I come from, independent of the organization that I choose to work in. There are values these come down from the actual profession and degree in which I hold. Part of that is looking at culture, right? And that kind of really is why we're all here today, and why Kate is here today, and why we're all doing the work we do with regard to the Native communities that we work with. Well, the National Association of Social Workers certainly have a definition for culture, and that is to describe the integrated pattern of human behaviors, certainly that is inclusive of thoughts, communications, actions, customs, beliefs, values, and institutions of a racial, ethnic, religious, or social group. So that is one definition of culture. And let's take a look at some Native-specific cultural risk factors. We know that oftentimes, and this may be or may not be the case where you currently work, but there may be issues around confidentiality, which is a trust breaker, right? Whenever there are folks who do not feel that their private, confidential, personal, medical or mental health or drug using issues are not going to be held in confidence, that's going to be a barrier. For example, let's say you decide to go to your local community clinic to talk about an alcohol problem you may think you may have, or you feel like you need to talk to somebody privately about. You go to your local medical provider and you say, I'm having some concerns. Do you have any suggestions? You get the support you need, you return home, and you start calling the phone numbers that were provided to you. A week later, you go back for a follow-up to that same healthcare provider, and you realize that everybody, including the front desk staff, knows about what was talked about. In fact, they may breach a confidentiality in front of the entire wait room and ask you, were you able to get a hold of those alcohol treatment centers? Were they helpful? There may be some good meaning behind those questions, but clearly there's been violation of HIPAA, really. And so examples like that, they may seem, if you were having a private conversation with the front desk lady and you were friends and it was over a private dinner, maybe that might not be a good example. But there's a time and a place, right? And that certainly is not the time or the place. And that can be a barrier. And those things happen more often than one would think. There are some other environmental risk factors that we should be knowledgeable around, and that is certainly a lack of social services that are culturally appropriate for the folks that we serve. That can also be a barrier to accessing help. Something else I'd like to mention is around circular migration. So when we have Native clients who do not show up for appointments, who may come and then sort of disappear for months at a time and then return for services, we know that folks often return home or move to the urban centers for jobs, for employments, and then return back home for ceremonies or for the death in the family or for take care of a family member. And so that can be a barrier to and increase risk factors for folks, particularly around adherence to treatment, so medications, et cetera, et cetera, et cetera. And we also know about our population that there are unresolved traumas, whether it be historical or contemporary. We know that boarding school, we know colonization, we know the reservation system, the we say historical trauma. I don't know if that's necessarily true. There are things that are still continuing to this day that oppress Native folks. So there's this unresolved trauma piece that we have to be aware of and be mindful of. And certainly just in general, we know that there is racism. We certainly all know that there is homophobia alive and well in this country and in this world. And that also is inclusive of, we have to think of our trans sisters and brothers as transphobia and certainly biphobia for folks who are bisexual. So we take these all into account moving forward, and this is all related to our value systems and the work that we do, and it's tied into delivering the best possible care that we can. Okay, so let me just ask you all, to think about this question. But what comes to your mind when you think of cultural competency? Another question I typically ask with regard to this question is, how many of you have ever, I'm just asking rhetorically, I don't need an answer, but how many of you have ever attended, whether it was mandated or not by your employer, to attend a cultural competency training? Most of us have. It's something that is often required. And so let's think about that for a second. Because I want you to think about this, another way to think about this concept is cultural humility, this concept of cultural humility. And cultural humility incorporates a lifelong commitment to self-evaluation and critique, redressing any power imbalances between the provider and the patient or client, and to develop mutually beneficial, non-paternalistic partnerships with communities on behalf of individuals. So I know that's a lot. Let's break that down to a little bit more digestible version. You should also know that cultural humility came out of the nursing profession. And just think about your own experiences. Going back to that example of you going into a provider and asking for help, or even if it's a regular checkup, the provider kind of can make or break the entire experience. If you've made it past a warm and welcoming, inviting reception personnel, if you've made it back, if you've had your vitals taken by somebody who you feel is respectful and affirming, and then you go on to actually meet with the provider comes in. If they're standing over you, with clipboard in hand and belittling and not really even asking your name or even just creature comfort questions like, how are you today? I mean, if none of that is taking place, that kind of sours the entire experience. And, you might be less likely to be turned back and see that individual. Well, the same goes for Native clients too. So let's look at some key distinctions between cultural competency and cultural humility. So cultural humility acknowledges that we can never become truly competent in someone else's culture. I could never say that I know what it's like to walk in your shoes, to live your experience, to know what your community goes through. Because I don't, that's not my reality. And I would never imagine to say that I'm competent in your experience. Cultural humility requires simultaneous processes of ongoing self-reflection and commitment to lifelong learning. So, in contrast, you could take a cultural competency exam and score 100 and say, yeah, I am competent in these areas. Whereas cultural humility is really about, you know what, I'm never going to know. However, I'm committed to learning throughout this journey, throughout my life, while I'm here doing this work. I'm committed to being open-minded and learning and understand that I'm going to have to do some thinking on my own and reflect on new information. And another key distinction apart from cultural competency is that cultural humility really does work to redress those power imbalances. So it's an active process, in other words. Now let's take that and place that in the backdrop with Native diversity and how we look at, now that we have an understanding of looking at the lens through cultural humility, how does that apply to Native people? Well, there are over 560 different federally recognized tribes. There are other tribes that are not federally recognized. There are tribes that are state recognized. There are tribes that have no recognition whatsoever. Then we fold in Alaska Native and Native Hawaiian diversity. There are over 223 tribal communities in Alaska, and then the diversity within the Hawaiian Islands. So we're talking about, when I say Native people, I'm barely just scratching the surface of how diverse Native people really are. So in using the lens of cultural humility, I would never say that I know what the Native experience is like. I could never say that. I could never say anything around, I know what the challenging issues are for Native LGBTQ people. I couldn't necessarily say that. What I can say is, I have some information. This is what I know. Let's have a conversation and share and see where I can learn and where we can share knowledge. That's a different perspective than saying, I actually have understanding of what you're going through. Let me tell you what you need to do. I hope that distinction is clear. So, as I said at the top, respect is kind of the bottom line, and that is as providers and our training, but I think respect is really the cultural, Native-specific piece that's missing, or that we can actually build upon and strengthen in an effort to make communities stronger. And that requires building trust. It's the cornerstone for all of the communities that we work with, and certainly requires us to be non-judgmental, right? There's no right or wrong. We're setting aside our biases. We work from a strengths-based perspective. We identify behaviors that support healthy lifestyles. And the example I routinely use is when someone calls to schedule an appointment. How often, in your own experience, are you ready to pick up the phone and schedule that dental appointment? How readily are you to schedule that annual physical checkup? Those are just common universal challenges that I think we have. And so when someone picks up the phone to schedule a follow-up appointment or an intake or what have you, I acknowledge that. And say, thanks, I know it probably took you some time. Or when folks actually come in for their appointment, that's even more so. Thank you for following through. Thank you for being here today. When clients show up for their appointments, they do better, they live longer. Thank you for taking the lead in your health. Let's get to work today. Kind of honoring that. That's identifying strengths and honoring those strengths. Certainly authenticity. Excuse me, I'm having a hard time pronouncing that this morning. Certainly being authentic in who you are and building that personal connection certainly can only aid the therapeutic alliance. I always advise folks to take time to establish a connection. Don't underestimate or undersell the. You're building a relationship, you're establishing trust, you're building that connection. That's what's been missing with Native folks and Western medicine. So this is a very critical step, and I want to underscore that. Introductions are critically important. Shaking hands, saying, I'm so-and-so, I've worked here for so long, I'm not from this community, or I am from this community. It's nice to meet you. Thank you for showing up today. You are affirming folks in their place. You are the expert in your health. I'm here to support you in that. Having that introductory, small, chatty conversation, kind of laying out who you are and what you're about, and offering an opportunity for them to share their who they are and what they're about is an important step. We certainly do not make any assumptions regarding sexual behavior with older folks. I'll make the assumption that they are not sexually active and then months later find out that they actually have an STD. Oops, my bad. So let's make no assumptions regarding sexual behavior, regardless of the age of our clients. And with that, make no assumptions regarding sexual orientation. We do not know how someone identifies based on their behavior. An example I use with that is, so a local community member, young father who's in your community, gets picked up, locked up for 6 months, might engage in some risky sexual behavior while incarcerated with other males, gets released, returns back to the community, is regarded as an upstanding father because he cares for his kids, identifies as heterosexual. I would never identify that individual as gay, even though he disclosed to me what he did in jail. He identifies as straight, therefore I identify him as straight. So we're building a relationship. That's and honoring their identity, their experiences, who they are as an individual in this world, and allowing them to be the expert in their care, in their health. Another sort of strategy that I will use, particularly with Native clients, really is looking at is around engagement. How do we engage folks into care? How do we engage and retain folks into care? I keep a stash of nutritious snacks around. So maybe some apples, protein bars. Maybe there's some sugar-free juice. I always think that I want to have something on hand because that may be the only nutritious snack of the day. Think of our low-income folks that may not have access to produce and veggies. I also am very mindful of the high rates of diabetes among Indian communities, and so sugar-free I try to keep on hand. If you don't have access to that, certainly just can be as simple as offering a glass of water. Someone walks in, has a seat. Can I get you a glass of water? Do you need? Those kinds of things. Also, meeting at a place of their choice. Maybe they don't want to come into your big, fancy, shiny building. That's a joke. So I'll make it an option. I can come to you. Is there a park nearby we can meet? Is there a private space where, maybe a coffee house where you can actually have a conversation? Those kinds of things. And I take a little bit of an issue with organized clinics, and I know this is a reality that we all work in. Clinics that are open Monday through Friday, 9 to 5. Well, you're cutting out a significant proportion of your community if those are your hours, and folks can't get in to see you during those hours because of work or school. So perhaps you can clear it with where you work and meet on a Saturday afternoon or a Friday evening or what have you. Just try to be. I try to be flexible around their needs. Again, it's asking that question: whose needs are being met? Is it mine because this is my work schedule and I'm sticking to it, or am I adjusting the schedule a little bit so that I can outreach to those folks who need support too? And the other little trick that sometimes I do is rearranging furniture. So rather than sit behind a desk and do an intake, I will pull the chair from around the desk and sit, knee to knee with the client. And that's part of also redressing power imbalances. When you sit behind a desk, it can be kind of intimidating, and it creates a physical barrier between you and your client. So sometimes coming around from the desk, that can sort of level the playing field, as it were. Okay, so also another strategy is to affirm Native culture and heritage. As I introduce myself, it's sort of protocol to identify myself and my name and my tribal affiliation. If you're sitting in front of a Native client, you might ask them if they haven't already mentioned, what is your tribal affiliation? Asking questions, just not invasive, obviously, but are you connected to your community? Those kinds of general questions. If it might be strategies to engage in small chat. Some folks show up with their family. maybe you go out and introduce yourself to them if that's something that the client wants you to do. Or maybe they're there to support the client, and there's a way that we can ask if how. So I have an example in my head. I'm trying to not tell it because it's a long story, but I'm going to have to break it down in a very simplified version. A community member from rural community came in for her regular HIV appointments and was always mentioning how supportive her family was and how supportive her kids were, and invited me to come over to the house to do a home visit, and I did. And actually, the kids were the ones who had set up a calendar on the wall in the kitchen area where everyone could see, and had listed out the medicine regimen on the calendar. And the kids were the ones that are going each day, crossing off, making sure that the mother took her meds every day. And I wouldn't have necessarily known that unless I had gone and seen it myself. So there are probably supportive, helpful family members in the mix in your clients' lives. Maybe we can tap into that as another way to get support for our folks. Certainly, if folks are very traditional or access traditional medicine or spirituality practices, we absolutely want to see how we can fold that in respectfully. If it's not our area of expertise, we can ask the client, is this an opportunity where we can, you can get the spiritual help you need, and I can provide some support too, and let's keep track and make sure that things are flowing. That's a great advantage if you have that. And incentives. We could draw a parallel and say that the snacks, the apples, the healthy snacks, might be considered an incentive. I'm talking more about like, let's say it's National Native HIV/AIDS Awareness Day, which happens every March 21st. Let's say you're having a big testing event at your organization, and everyone that comes in to get an HIV test will receive a $10 Walmart gift card or a $10 gas card. And, there is this, in the literature, it speaks to this sort of provocative dilemma with regard to incentives. Are folks only coming in to get the HIV test because they want the $10 Walmart gift card? Or are they coming in because they're individually motivated and want to take charge of their health and they want to know their HIV status, and so that's why they're coming in? And that we really shouldn't be paying or incentivizing folks to take charge of their own health. Okay, so those are two very, just the bottom line is where I stand in my own practice is, of course, if folks are only coming in for their $10 Walmart gift card, and then on top of that getting an HIV test, to boot, awesome. I could care less if all they want is a $10 card. The fact is they're getting their HIV test. They're knowing their status at the end of the day. And on top of that, here's an opportunity where we're building trust. We're building upon that relationship that we've established. And so we're only just making things, I think, not to place judgment, but it's a better situation if, in fact, someone's only coming in for the incentive. We have an opportunity to do that small chat, that check-in, build rapport, build connections, et cetera, et cetera. And as I mentioned earlier, we work from a positive service delivery model, which is ultimately a strengths-based approach. We collaborate. We work with folks in other departments. We identify strengths and we use them as a way to empower the folks we work with. We convey authentic interest. We acknowledge and provide support for positive steps. And folks who work on the front line, you all, you are my peeps. You can perform a level of advocacy that managers and other folks cannot do because you have the frontline perspective. You know the trends that are going on. You see what's taking place in the community. You know very often who the gatekeepers are of information. So, those are all strengths, and we can use those to build a better community, I think. We talked about building trust and asking whose needs are being met. I talked about the office location. Something I didn't talk about was complex, bureaucratic, organizational paperwork and processes to get the services one needs. That can be a barrier. We want to make sure our intake forms reflect diverse clients. So specifically, with regard to our transgender clients or trans clients, think about your own intake form now. On your intake form, does it ask for someone to identify their gender, and does it leave male, female as your only two options? That is a turnoff for our trans clients. So maybe another way we can look at this is revising our intake form to ask two questions. One question, the first question being, what gender were you assigned at birth? And having an open space for folks to fill in. And the second question is, what gender do you identify today or now? And having a blank space for folks to fill in. So those are just little things that we can do. And we can add that. I have a question here about this. The slide on building trust talks about research. Where can I get the reference? I will be happy to provide that when I finish this and look back. Let's be in contact them. And these slides I'm happy to share, and Kate's happy to share them. I think there's even an opportunity for that, for Kate to do that. But at the end is my contact information. Certainly, yes, we'll talk about references. And lastly, okay, so I'm just looking at the slide. Bear with me. Okay, so other barriers to solutions. We talked about our own personal values. That certainly can get in the way of the work that we do. And that requires the personal reflection. So if we have biases, for example, when as a product of the DARE program and the Just Say No campaign and Nancy Reagan, the early to mid 80s, 1980s, and then working in an environment where the complete opposite is embraced. Just being aware of that disconnect and reflecting on it and learning more and being open to education actually is what undid all that. I was actually able to see why just saying no is not may not be the most helpful approach to folks who use drugs and alcohol. But that required personal reflection. So that's what I'm trying to get at. Certainly there are other barriers such as limited referrals. If you live in a community where there's very limited social service programs or opportunities, that can be a challenge. We all work within funding mechanisms that ebb and flow. Sometimes we have great funding, sometimes we don't, and that can impact the solutions that we can offer. You can be working with unrealistic timeframes. So if you have 3 months to complete 20 deliverables, you might be in and over your head. And there are other specific barriers that I'm not mentioning here. And just a word about confidentiality, a little bit more in depth. The issues of drug use, sexual behavior, sexual identity, some of those can be very highly stigmatized within Native communities. And I just want to really underscore that it's really critical that we maintain the highest level of confidentiality. If you and I are serious about improving the quality of life for all folks, not just Native folks, but all folks. And again, this is where the rubber meets the road with respect to building trust. This confidentiality piece is critical. And some things that I'll do with all clients, but certainly with Native clients as well, is that not only will I talk about our agency confidentiality policy, something they may have signed forms while in the waiting room, I'll actually take the time and read through it and talk about what it means to be a mandated reporter, what I can and cannot do, like how the system is structured within the organization I'm working in, the double lock situation, so that their chart is a confidential chart. It's on a need-to-know basis. It's kept in double lock. Kind of walk them through the process and be real about it. This is what I'm able to do. If something, for whatever reason, I can't sugarcoat it. It may happen, and be real about that. But communicate that it is in my own practice that this is very important to me and that I don't take this lightly. When I say I work to keep your personal information confidential, I honestly mean that I'm working hard to keep your personal information confidential. If something like that is, breached, I we obviously take responsibility for that. And so that's the real conversation to have. And create it, and maybe it's an ongoing conversation. Maybe it's something that's talked about not just at your first appointment, but maybe it's something that's brought up and asked about. Are you comfortable here? Has there been any challenges with regard to your privacy? I mean, that's really going above and beyond, and I think that's really kind of what needs to happen with regard to Native folks. So, again, these are my own 2 cents, but I put that out there because I've heard the horror stories, I've seen the horror stories, I've experienced the horror stories. And I want to just underscore that confidentiality is a critical step, and that one that we should not be minimizing. Okay, so moving forward. This is a visual I have with regard to how that trusting relationship certainly impacts quality of care. When trust and respect and confidentiality is in place, certainly we have the ability to gain a complete health assessment. So folks will be able to be maybe a little bit more forthcoming about, risky behaviors that they're engaging in. And as a result, we can respond with high quality healthcare and services. So when we have an accurate assessment of what the situation is, we can then respond accurately as well. This helps, this helps reduce cost because folks aren't jumping around from provider to provider to provider. It's a more streamlined, we can provide more streamlined services. And we can actually provide referrals that actually reflect the needs. So that's another way we can cost save. All right, so this is a little bit more of my own 2 cents. These are 5 steps that I've developed. It's not patent pending, so feel free to use however you will. But these are just my own thoughts on paper with how I engage Native clients, and I've boiled it down to 5 steps. So step 1 is really understanding, we'll go through each one, but step 1 is really understanding Native worldviews and what that means. Step 2 is understanding the roles of Western medicine and how that's played out and why that can be a barrier. Step 3 is really, again, that piece around providing formal introductions. Step 4 is how I've explained confidentiality, which we just discussed. And step 5 is really understanding that circular migration piece. So this is kind of putting everything we've talked about more into concrete steps that I hope that are helpful for you. Okay, so step 1, understanding Native-centric worldviews, indigenous worldviews, if you will. Indigenous worldview perspective. I'm just thinking of the different ways we might frame this. Many Native people certainly do not conceptualize themselves as most important, which is in contrast to other perspectives. Native people might conceptualize the world based upon their membership to a larger community, a larger tribal identity. As I mentioned earlier, there's protocol. When I'm in a room with other natives to identify what tribal affiliation I am, because that places me within a context that's not about me, it's about where I come from. And that's an example. Individual self may be secondary to family and community. And I know you mothers out there will get this, and fathers too. I don't mean to be gender biased. But I'll use my own mother as an example. She puts everyone first ahead of her own needs. And, that's kind of, I know that's a stretch, but I think, when you identify within a larger tribal context, you're not really looking out for your own needs, you're not working out for your own needs, you're looking out for your community's needs. And that's kind of what I'm getting at. And part of that is the word family. When a client says my family, they may not actually be talking about their blood relatives. Family in the Native context can certainly, and does include often, in-laws, people of the same clan, distant relations, other people in the community, adopted members. So family is a broad term that we need to really that we may need to ask more questions about. So when you say family, who does that include? Part of knowing and understanding Native worldviews, that we understand that most medical models really only focus on the individual, and that's for appropriate reasons. In the example I used with the child who keeps the calendar and medication, um, uh, keeps on top of the medications and when they're taking and when they're not taking. We might only see the woman was only coming in individually, and the services and what was provided and the support that was provided to her was on an individual level. It wasn't until we got to see the actual how things were playing out and how involved the children were that it wasn't necessarily an individual journey on her part, it was actually collective. We know that stigmatized health concerns certainly can call attention and create shame. So that's why confidentiality is so important. And really valuing the importance of modesty and nonverbal communication, body language, the small chat, what the stuff that's disclosed, that's mentioned sort of in between the lines. It requires an ability to be able to read all that. All right, let's talk about step 2, which is understanding the role of Western medicine. For many Native people, Western medicine has ties to historic and traumatic experiences. Up until the 1970s, where we're having Indian Health Service perform involuntary sterilization upon Native women. I mean, those are still resonating. Those still resonate in the experience of boarding schools. Even though boarding school isn't related to healthcare, it is because it's a Western construct. So this is kind of this is another place where the rubber hits the road. Being understanding or being mindful of this is important. As I mentioned, the boarding school and how that, in an effort to colonize, was actually really destructive and genocidal. Let me know if you have questions about step 3. It's really just trying to look at this again. So I think understanding that Western medicine, I'm just trying to do a visual in my mind. So visualize this with me. Your Native client going in and accessing health services at your local clinic is different than being a Native individual and accessing health and wellness from a traditional healer. They're going to be two different, there's two different ways of addressing health. One is more affirmative around someone's culture. One has historically been genocidal and colonizing in nature. So however you can, I think everything we've talked about up until this point, if you can sort of follow along that track and be affirming and be respectful and build trust and ask questions about one's family and be respectful and be interested in someone's community and know that you represent, even if I would go as far to say if you're a Native provider, knowing that you represent a system that has created harms, historic harms, I think in and of itself is helpful. So maybe you don't have the exact words, or maybe you're a little nervous interacting with Native clients, or you're unsure of where they're from. But I think if you're mindful of even just the harms that have happened in the past and how we can work to not recreate them, that's gold. You're on the right path. So step 3 is, again, providing the formal introductions. We know that, or I know that it's something important, and that professionalism really discourages that personal interaction. So sitting behind the desk, as I mentioned earlier, holding the clipboard in front of you, literally standing above someone who's seating and talking down to them about their own health care. I mean, those kinds of things, you'd be lucky to see if somebody comes back for their follow-up appointment. Okay, so we mentioned all that. Explaining step 4 is explaining confidentiality, which we talked about a little bit earlier. Building that connection, really what it comes down to. And explaining the steps of how confidentiality is operationalized in your organization. Step 5, and that's that circular migration piece again. So we know that folks travel sometimes daily, weekly, monthly from reservation and rural communities to urban areas, and vice versa. So, it certainly can be a challenge if you're a provider and your folks don't show up for months at a time. We might be quick to label them as resistant, non-compliant, hard to reach, unmotivated. But what might be going on is that they are taking care of family and are expected to as a responsibility, a cultural responsibility. And so all I can really say is just know that folks can go back and forth between home and where you're located, and that we really shouldn't be pathologizing or labeling clients, but because there might be something else going on in hand. That's just a helpful reminder. All right. Let's talk about supervision. And I think this is the last sort of section for today, if I'm not mistaken. And supervision, in general, is a luxury, in my opinion. I think if you have access to supervision, use it for all it's worth. I have worked in places where there has been no supervision, where there might be stated supervision on paper, but what you actually get is not supervision. So, it typically can happen on 3 levels: administrative, evaluative, and clinical. Consultation with your supervisor can be a component of decision making with your clients. We know it may not always be available, and it may not always be helpful. I believe it's your ethical obligation to seek clinical supervision if you are providing clinical services, and certainly not work under case evaluation only. 3 goals of an effective supervisor certainly are to assure delivery of services, assure delivery of quality treatment and services, aim to create a positive work environment, and develop and build upon staff skills. Certainly, effective supervisors set clear expectations that are understood by all. They can provide feedback with respect in a timely manner. They teach needed skill sets, provide a supportive and respectful environment, and lead by example. I would go as so far to say that many of you have worked with folks that did not provide or that were not effective. But we work with that too, and we advocate for our needs, right? One of our needs might be related to the stress that we experience at our job. Stress certainly can begin with a life situation that knocks you out of balance. And when life situations are perceived and cognitively appraised as distressing, certainly it can lead to physiological arousal. So fatigue, illness, you can get sick. When I get super stressed out, my joints hurt and I have to take, a little bit of ibuprofen. So we know and we have experienced stress, and let's talk a little bit more about it. Certainly there can be biological reactions to stress. Your brain, muscles, skin, limbic, emotions, and your nervous system. There can be psychological responses. There can be thoughts and feelings, and there can be sociological surrounding environments to stress. Folks who work among highly stressful, when I'm thinking in mind again to the frontline providers, those are the folks that have in the research actually has been reported or suggests that there are higher levels of stress for doctors, for social workers, for counselors, for outreach workers, etc., because they are seeing the frontline stuff. So that can all contribute. And some symptoms, are you skipping your rest periods? Are you skipping meals? Are you overeating? Are you having increased overtime and no vacation? Are you having increased physical complaints? Are you self-medicating? Are you, perhaps imbibing alcohol a little too much? Do you notice emotional changes, with depression, anxiety, and many others? These are things that we need to be mindful of. When we experience that emotional exhaustion, that can lead to burnout, and that's not a good place to be. Burnout is an adverse work stress reaction with everything that we just described to a level of cynicism, emotional exhaustion, excuse me, and feeling like ineffective in our job and what we're doing. And that's not a good place to be. We particular um, phase of your career or your job, get help, right? We don't need, it's not helpful. So, stage one, certainly the honeymoon, everything's going well. Stage two, you might have a fuel shortage, fatigue sets in. Stage three, you're starting to experience chronic symptoms. Stage four, actual illness can develop. And stage five, you've hit the wall. We don't want that to happen. So, I want to say simply put, for your sustained, unmanageable, painful stress, or if you're going to, for sustained, unmanageable, painful stress, your response is your responsibility. It's on you. I know that's kind of might sound a little insensitive, um, but who is the expert in your own healthcare? Certainly not me. Certainly not your supervisor. It is you. I encourage you to seek help. Set limits and boundaries. I was having this conversation the other day with some folks, some frontline providers, and we had this conversation around boundaries and what good boundaries are. And we were all saying how that conversation around boundary setting between being frontline providers and our staff, and our supervisors and management is not something that routinely happens. Maybe after today, and if you're having challenges with boundaries, maybe you're getting assignments and tasks and being given work that is well beyond your 40 hours, work week, and you're being asked to do things that are, with that, we get asked to do things that are within reason, that are not in our job description. I realize that, but there's a point when things are getting when it's starting to impact you, and how we set boundaries. I think that's a critical conversation that, if it hasn't happened at your workspace, maybe we do a brown bag at your place of employment, and you organize it and you bring folks in, and we begin the conversation around boundaries. Maybe that's a strategy that needs to happen where you are. I'm just offering maybe a strategy. Managing symptoms. So, taking time off. I know sometimes we feel guilty about that, and in that guilt in and of itself, might signal a need to do some self-reflection. And somebody mentioned this to me, and I actually have held by it. In addition to exploring new interests, new areas, and new challenges to keep things fresh and to keep the work alive and interesting and something that we want to explore more. Somebody also recently told me to actually continue doing the things that you feel really good about. And the example that she used was that even though she's in a really stressful PhD program and information is presented to her nonstop, and she feels overwhelmed a lot of the time, what she does as a way to prevent burnout is to be involved in her salsa dancing. It's something that she's very good at. She's spent many years doing. She loves to do it. She loves the physical aspects of dance and the aerobic exercise that it provides. And, it gives her a chance to kind of step away from her demanding role as a student and participate in something that she feels that she has a sense of mastery in. And so I think that's a beautiful example of another strategy that we can employ with regard to preventing burnout. So, humor. Humor is another way to prevent burnout. Meditation, if that's something you're interested in. Attending ceremonies, whether it be traditional, whether it be non-traditional. Accessing prayer and spirituality. It's important for me as a Native individual. It's important for the clients that I work with. It might be something that's important to you. Tapping into those resources. Relaxation techniques. So breathing, just focusing on your breath if you're in a stressful moment. Taking 3 deep breaths at your desk can honestly change your day. So I encourage you all to maybe, if you're sitting at your desk right now, to take a deep breath in and take a deep breath out and repeat that for 3 times. Your head will feel so much clearer. And, exercise, make it fun. So Zumba, the salsa dancing example. I like to go on hour-long walks around my neighborhood. Just kind of gets me out, gets me in some fresh air, and I listen to some music at the same time. It's a good thing. I'm sure you have your own examples. Okay, so I want to say thank you for you taking the time to sit with me this morning and the rest of the participants. There's my email address and my phone number. I'm available if you have questions. Again, this was just to provide a framework for you all in doing the important work that you're doing. And if there's any questions, I'd be happy to take them now.
Thank you so much, Matt. We always enjoy hearing from your personal experience and the great insight that you have. So really appreciate you. Thank you for presenting for us. And please submit any final questions that you have. We can try to get a couple in yet if anyone has a question. But I'll just remind everyone that we'll be sending a follow-up email to everyone who attended. And if you have friends that registered but weren't able to attend, they'll also get an email with the recording link. You all will get an email with the recording link as well as the CEU request form and handouts of the presentation, so you'll be able to refer back to that later. If there are no other questions, I'll just thank Matt one more time for a really great session. Matt, did you have anything else you wanted to say before we finish up?
No, thank you. I wish everyone well, and I'm glad you were all able to join. And if you have feedback, I'm always open to hearing it. So, have a blessed day today.
Thank you so much, Matt. And yes, thanks so much for joining us, everyone. And we hope to have you join us again for our next ESAS webinar coming up in July. We also have a behavioral health webinar in which Matt is going to be joining us again. That is July 6th, and he's going to be presenting on the historical overview of Native LGBTQ and Two-Spirit identity. So we're looking forward to that a lot. And have a great day, everyone, and we'll see you next time.
Thank you.